Open, outspoken, it's ophthalmology off the grid, an honest look at controversial topics in the field. I'm Blake Williamson. Welcome to another episode of Ophthalmology Off the Grid. In this episode, my co-host, Dr. Neda Nikpoor, and I are excited to welcome Bill Trattler for an in-depth conversation about keratoconus. During our chat, we discuss how genetic testing, and specifically the AvaGen Genetic Eye Test, is improving how we make refractive decisions. It's improving the utilization of cross-linking to meet refractive goals, and it's also some of the exciting technologies coming down the pipe. Coming up on Off the Grid.
Support for this podcast comes from Bryn Mawr Communications. BMC produces a number of informative podcast series spanning a variety of topics in ophthalmology. Discover a new show at itube.net/podcasts.
Welcome to another episode of Ophthalmology Off the Grid. I'm here with my co-host, the one and only Neda Nikpoor from Hawaii. Neda, how you doing?
I'm doing great. How are you?
I'm well. So I'm just finishing afternoon clinic, and Neda is just getting done with her morning clinic. So just the perfect time for us to squeeze out an episode of Off the Grid. Thank you so much. I appreciate it. And this is such a cool topic. You and I were talking about, different things, and you had some great ideas about things that we should talk about in AvaGen with genetic testing for keratoconus and other diseases is kind of hot on the scene now. And I had a recent experience with it, and I said, man, that'd be so cool. So we tried to find an expert on keratoconus, but we couldn't find an expert. So instead, Neda found a very obscure, relatively unknown ophthalmologist. Can you introduce our guest?
I would love to. I'm sure no one has ever heard of him. So it's my pleasure to introduce to the world Bill Trattler. Now, obviously, everybody, myself included, I think when we think keratoconus, we think of Bill. And in my mind, Bill Trattler is my go-to expert for talking about all things related to keratoconus. And I met Bill when I was a resident in Miami at Bascom Palmer, and his dad staffs our emergency room, and he interacts with us. And I remember sending patients for cross-linking to him before it was even FDA approved, back when I was a resident. And so I've always kind of had in my mind that he's on the forefront of doing things for patients who have keratoconus. And I first learned about AvaGen through him. And I'm really excited that we now have, FDA approval for genetic testing for keratoconus. And I'm sure he has much more experience than you and I combined. I've had a little experience. I know you have too, so we can kind of talk about that. So yeah, I really wanted to use this as an opportunity to pick Bill's brain about how he's using the genetic test, what he's doing for keratoconus in general these days, and, how Epion is going, what's new for him, and what he sees on the horizon for these patients. So Bill, I am excited to hear your thoughts. You can start in whatever order you want, but maybe we can start talking about AvaGen first and how that's fit into your practice.
Absolutely. Well, thank you, Blake. Thank you, Neda, for inviting me to be here. It's so fun to be here with you both. And obviously, keratoconus is a fun topic to talk about. Obviously, there are many fantastic experts in keratoconus around the world. So I do my part, but I think we all learn from each other. So I've been excited. When AvaGen came on board, I was like, wow, genetic testing, is that going to help us? And they've really come together to put together a nice device, because it explores the genes that are increased risk for keratoconus and give an overall score, because patients could have some genes that are high risk and some genes that are moderate risk and some that are lower risk. We come with a risk score that we can help at least use to guide us on understanding the patient's risk for keratoconus. I know I've used it for my patients, but I'm curious if what your experiences are before I jump in on my thoughts, Neda or Blake.
Yeah, so I'll give you my anecdote. So I was literally, so one thing is, I think that I need to do a better job of doing this on multiple people for multiple reasons. I first used AvaGen, I don't know, maybe a month or two ago, where I had a patient who was coming in and had a cornea that just looked abnormal. The final D was off. There was no posterior elevation, but it was just kind of one of those corneas that definitely gave you pause. It was one of those questions where it wasn't LASIK versus PRK. It was definitely not LASIK, but it was PRK versus do nothing and just monitor this patient and maybe even cross-linking down the road if we get some posterior elevation on the tomography. And this patient was super bummed about that. And then it kind of hit me. I said, we started talking about eye rubbing. I showed her Damien's website, defeatkeratoconus.com. And she literally called our practice back and said, wait a second, like I rub my eyes all the time. Like she was one of those that like, it was like a light bulb went off. We all have this keratoconus patients like, no, I never rub my eyes. And they do. But she was like, no, that's what I do. And she was like, Dr. Blake, I just feel like if I stopped rubbing my eyes, I really feel like I could get PRK. And she was like a -4, -5. She really wanted this done. And so I said, you know what, she was like, if there's any way we could figure out if I'm at risk. I said, well, actually, it's funny you say that. There is this thing. So it was like the patient was suggesting to me, which I'm embarrassed to say, but that's the truth. And I said, well, actually, there is a test now. It's, fairly new, but it's, it costs $300 or whatever it was. And we can figure out if you have the genetic sort of, code to be at high risk. And in fact, she was very, very low risk. It was as close to zero as you can get. And so in her mind, she was like, you know what, that means that this is all mechanical for my specific case. And I promise you that I will not touch my eyes. And we did like a month-long thing where she didn't touch them at all. And she was like, I can do this. I really want to move forward with this. I agree to, and I consent for, closer testing. We're going to do tomography like every 6 months for, probably a couple years. And if I have to do cross-linking in the future, I'll do that. I really want to roll the dice and do this. And I don't feel like it's rolling the dice because I have that negative AvaGen test. And she and I felt very comfortable. She underwent PRK. She did wonderful. It changed her life. And she actually went on Facebook and did this big write-up about us and how we went the extra mile for her. And she felt so supported and she felt like all her questions were answered, et cetera. So it just ended up being a huge win all around. So that was my initial foray into AvaGen.
That's an incredible result. And that's why it's so helpful. I had the same identical case, exactly the situation, same refractive error. She's 26. And that negative test made her feel much more comfortable about proceeding. She's still trying to schedule because of COVID. She slowed down a little bit, but she is planning to do it sometime in the next couple of months. But she felt much more comfortable knowing that her test was negative.
That's awesome. Yeah, that case is really great, Blake. And I think you're right. It definitely makes us feel more comfortable when we have somebody who's a borderline case. In your case, it was borderline PRK or nothing. My first patient is actually a little bit different, but kind of a similar decision tree where he's like a 24, 25-year-old low myope with some astigmatism, and his myopia and his astigmatism are increasing, and his scans are not completely normal. They're a little bit abnormal. Like there's a little bit of skew. His posterior float looks okay. His epimap, which we get anytime there's a patient who has suspicious corneas, is also kind of equivocal. And the thing that really did it for me, and his Berlin did not flag, which I thought was interesting because looking at his pentacams myself, I was like, oh, they're not entirely normal. And he has increasing myopia and astigmatism. The thing that really solidified my interest in getting genetic testing for this patient was we actually have, I started talking to him about eye rubbing, and I started talking to him about keratoconus and the risk for progression and all that kind of stuff. And he was like, oh, I rub my eyes all the time, kind of like your patient. And he's actually from the Big Island. And I've talked to Bill about this. We have observed a significantly higher percentage of keratoconus from the Big Island than from any of the other islands. And I'm actually working with AvaGen. We're doing a research project to characterize the genetics of the keratoconus on the Big Island to see if there's, a different variant that's there, if it is, the Samoan or Pacific Islander or whatever ethnicity is out there, if it's already in their database or if it's not. So we've been working on getting that set up. And then I saw this patient and I'm like, man, you're like kind of borderline. And he really wanted LASIK and he really did not want PRK. And traditionally, the way to figure it out would be, repeat his refraction and his pentacams every 3 to 6 months for a while until you have stability and until you're really sure that he's not progressive. But he wants LASIK like yesterday, and he really doesn't want to go through PRK, healing time, and all of that. And so I basically told him, I'm like, well, we can get this genetic test, and it's not going to say you absolutely don't have it or that you absolutely do, but it's going to help stratify your risk. And he had already been, saving for refractive surgery so he could afford to do it. And interestingly, I've been talking about this test with patients who have keratoconus for months, ever since I found out about it. And I've been trying to get, siblings or family members, people who are maybe kind of suspicious, just trying to get anybody who has actual keratoconus to get the test. But in my experience, I don't know if it's similar where you guys are, but I imagine this is kind of a worldwide problem. Oftentimes keratoconus patients just don't have the financial means to pay, $300 even for a test that's not covered by their insurance. And so I have yet to find a patient who can afford to do it other than a refractive patient. So I'm actually still waiting. We're going to do his test in like this week or next week, and then we'll get a result soon. So I'm curious to see what that shows.
Absolutely. No, that sounds like a great patient to get a test on. For me, it's more of a rule into PRK versus not if you're suspicious. I just worry that, the LASIK flap can sometimes weaken a cornea that is at mild risk, maybe from not just from genes, but maybe from rubbing, who knows if they look abnormal. It's just so hard to know. LASIK, but PRK we know has so much lower risk for progressing than LASIK. At least that's been my experience and what some data shows. So, you can definitely consider LASIK, but you're going to have to follow them, and they may need cross-linking, as long as you follow them closely and they don't escape from you. That'll be the key.
Yeah, absolutely. Definitely.
Yeah. So, oh my God, these are such great topics. I was going to share one more thing. Do any of the guys have any corneal dystrophies in your practice? Like granular or lattice or Reese-Bucklers? You guys ever see cases like that?
Very rarely. They usually go to the cornea specialist down the street for me.
Even though I am the cornea specialist down the street, I don't really see much of that.
And I've had a couple, and it's more because they're coming in there thinking they may be eligible for refractive, and then you see that they have something wrong with their cornea. So just throwing out that this test is really great because it also tells you if they have a dystrophy. So that does help overall if there's anything, even if it's subtle, and because they're 20 and they don't have any obvious signs, it also helps rule that out for your patient, which is rare, but can be helpful.
So Bill, I'm curious. I want to know how else you've incorporated this into your practice, because I'll paint the scene for you. I was at we were just at AAO in New Orleans, right? And I was at Brennan's with the AvaGen people, and just having a nice leisurely lunch. I think I was on my third mimosa at the time, and I was letting them know. I was like, man, I was telling them that story I just told you guys, and I somewhat stupidly said, so where else can I use this thing? And they looked at me, they were like, well, you should probably be testing every single child of every keratoconus patient that you have, like Neda just mentioned. And I was like, man, you're right. Why am I not doing that? And I feel like I'm fairly tuned in. Like, we have this podcast, like I go to meetings, like 1/4 the amount of meetings that Bill goes to. And I feel like that's enough to be somewhat plugged in. And I just feel like I'm ignorant to all the different places I should be or could be using this, because it's so true. I mean, I have many cones patients that are, 35 to 55 years old. And I'm like, why am I not having your teenager in here? Because we know that's the time to intervene. But in your practice in Miami, are you having similar issues where they can't afford to do it? And how do you get around that? Is it how you educate them on the importance or the value of it? Where are you using this routinely? I'm sure it's more than just refractive surgery, PRK rule-ins.
Right. So I think it's a combination of what you just mentioned. What I do is I like to get the family members in, and we do an actual exam where we actually do the Pentacam and we check their vision. So if they're completely normal, and let's say they're 14 years old, again, of course we could definitely do the test to see if they have genetic risk factor, but their price jumps in. So it would be really for the patient that are kind of suspicious. So you run out a 14, 15-year-old family member with keratoconus, and they have some suspicious signs, but they don't really qualify for keratoconus. That's the right patient, because you're suspicious. Should they come back in 3 months, 6 months, a year? I'm not necessarily doing on every, recommending on every single family member, because again, of cost issues. But just the patient that have some abnormal findings, that's where I think it's helpful.
Okay, so they have to have an abnormal tomography. And when you say, what do you mean by that? Does their final D have to be off, or is it more about seeing a posterior float that's awkward or weird, or inferior steepening, or what? Where's the nuance there with okay, that's abnormal?
Well, I mean, I think you guys are both quite experienced in keratoconus care, so it's just a patient that is not quite normal. It could be that they have progressed. They go, oh my gosh, I have progressive increase in my astigmatism over the last 2 years. Their glasses have gotten worse and worse and worse. Or it's right that makes you suspicious. So they went from 1 to 3.5 diopters of astigmatism, that's going to make you suspicious, even if the topography looks normal. Or maybe, again, some subtle changes in the symmetry of the cornea. So I think there's no exact answer, because again, we're trying to catch things early, and there's so many different presentations of keratoconus.
I think for a lot of the family members, it, at least just thinking about like overall cost to the system, in addition to cost to the patient, just like Bill is saying, I feel like getting a family member in for an exam is covered by their insurance. It's, it's less cost both to the patient and to the healthcare system overall to check a refraction, do a slit lamp exam, get some scans on them, and at least establish a baseline. And so even though I've talked to every patient about it and encouraged them to get testing, like primarily I'm talking to them, educating them that, this can run in the family. Do you have other people in the family that have glasses or contacts, have astigmatism? Are they eye rubbers? Do you have kids? Are your kids rubbing their eyes? And I'm, constantly trying to educate them on that and educate them to talk to the people around them, especially my patients that are coming from the Big Island. Like I was saying, it's crazy. Like we have 10 times the number of patients coming from there than we do from Oahu, and they're like 10% of the population or something. So they're way disproportionately represented. And so there's all kinds of things that we're doing with, a school screening program that we're starting next year to try to identify these patients earlier on the outer islands. And I think at the very minimum, I try to get them to go in and see their optometrist and get a baseline exam. If they're on an outer island and they can't get a pentacam, then at least they can get a refraction. And then sometime I tell them, oh yeah, just bring your family members or some family member of yours, whoever you're worried about, to your next appointment, and we can scan your eyes. And just like Bill is saying, thankfully all of those patients so far, the family members, I haven't really caught anybody that has anything. But I think if I were to have, a patient that looked suspicious, it's nice to know that I have this tool at my disposal and not just the normal of, oh, let's just watch and wait and see if you're going to get worse or not. So it's really nice that we don't just have to slowly watch them lose vision. We can actually intervene earlier. It'll be really interesting too, whether we can use genetic testing as something that we can submit to insurance to get cross-linking covered, because right now, it's so frustrating that we have to wait just for progression for patients. So I don't know if you have any thoughts on that, if that's something that they're even working on getting that worked in for insurance purposes.
It's not on the label, so they will not want to do that because they would prefer not to. Insurance prefer not to pay.
As like to prove that, oh, this patient is high risk for keratoconus and they have strong genetic markers for it and an abnormal topography. Do we have to wait for that topography to get worse? That, I know it's talking the can't really talk.
Right. I think the issue is that insurance companies prefer not to pay for cross-linking, so they're not going to make it more easier for patients to get this procedure. So they're going to just follow the label exactly, and that's what the label says. So that's what they're following. But they didn't look at genetic testing at the time of the FDA clinical trial in 2008, so it's not part of it. So I don't expect the insurances to really change. We could be pleasantly surprised, but I don't expect that.
Bill, what about so I just got my cross-linking whenever Glaukos bought them, and I'm guessing that was probably similar for many providers around the country that have been on the fence. So I'm relatively new to this. I'm just kind of getting to that point where those patients are now a year out. My original patients are cross-linked, and they're coming in wanting PRK. So what are your thoughts about that? I know that some people, in Europe do it at the same time, sequentially. But my thought was to wait a solid year and just kind of look at the image maps. What are some of your cutoffs for people that you would consider doing PRK, and how do you kind of decide whether yes, this is someone you will do PRK on a year later after cross-linking versus, oh, you know what, I better not touch this one. They're not a candidate for a corneal-based procedure.
Blake, you asked a fantastic question. Well, first, you probably noticed that many of our patients have a little better shape to their cornea. They're a little flatter, and hopefully the shape has improved a little bit. Since I have the Vizix eye design system, I need patients to be 20/25 or better as a minimum. Like if I had someone who's 20/40, the eye design system won't improve the corneal shape enough, so they still have reduced best corrected visual acuity. So I'm not solving that much. So that's my first cutoff. Is I like to treat patients only that are 20/25 or better. If you have the Contour, the Alcon system, that's just topo guided. I know that a number of people across internationally, and then in the U.S., Mark Lobanoff, Carl Sunsafe, and others are doing Contoura. and they're doing more irregular shaped corneas. In fact, I did send someone from Miami all the way up to Mark Lobanoff a couple of days ago. Well, he went a few weeks ago and just had his treatment this week. Mark sent me some pictures with the patient happy. We don't know the result yet. He just had it this week, but they can treat some irregular corneas. But for me, the first thing is they have to have good visual acuity. So these are the mild cases. You're crossing because you identify them, and they're seeing well. And then typically I like patients that have low refractive errors, like -1 to -4, -5, and have reasonably good corneal thickness. And we'll do eye design PRK, and they can do quite well. Again, it's just a very tiny subset of my patients that have keratoconus, but those are patients that typically come in. They wanted laser vision correction. They didn't qualify because we identified mild keratoconus in the beginning, and we did crossing first and then PRK. I'm not a big fan of combining. Just to remind you that in Europe, they have different systems, so they can do a short burst of a high energy, low time frame cross-linking, which we don't have in the US, and that's how they avoid some haze. But if you're trying to do a 20, 30-minute cross-linking after PRK, you're gonna get high degrees of haze. So it's not really an option for simultaneous or same day PRK combined with cross-linking.
I would add to that. I think in my experience, I feel like, I've been cross-linking since I've been in practice, and I'm always kind of looking for that patient that has mild enough keratoconus that we can do cross-linking, and then a year or two out, you could consider, once their cornea has stabilized and their topographies are stable, then you could consider doing PRK. Bill has shown some really great data that, people can continue to have flattening and changes of their corneal shape out to like 7 years, I think, if I'm not mistaken. And so I, just like arbitrarily picking a year, I feel like is probably fair for most people, but may not be true stability for everyone. Unfortunately, in my experience, it's been that most of the patients that are being referred in for cross-linking are being referred in at a moderate or late advanced stage of keratoconus, and they're so far beyond something that we could correct with a low amount of PRK. And so it's been really hard to find somebody who would actually have best corrected acuity that would do well. And I'm hoping that that's something that, as we get farther along in this and there's more awareness in the optometric community, especially about cross-linking, then we'll catch patients earlier. We'll be doing cross-linking earlier on patients, and then we'll have more people who have mild disease that are now candidates for some sort of refractive procedure. I had the other refractive procedure that I feel like not a lot of people talk about is ICLs. And I had a great case of a super nice guy who's had cross-linking already and was like a year or two out when I first met him. And he was, a very high myope with high amounts of astigmatism. And I kind of talked to him about expectations, and basically I sat at the forefront myself and with my optometrist across so many different methods, contact lens over refraction and regular refraction, maxing out his refraction with 4 diopters of SIL, because I wanted to see what was his spectacle best corrected acuity with 4 diopters of cylinder, even though he had like 6 diopters if you really did a true manifest. But when you maxed out the SIL, he could still get to like 20/30, and he was happy with that. He was like, I just want to be able to see my kids and play with my kids without having to put contacts in my eyes. And I don't need to see 20/20. I know the quality of vision is not going to be as good, but if this is as good as it gets, I'm happy with this. And I put toric ICLs in both eyes, and he ended up like 20/25 and actually better than I had got on refraction. And so I feel like that's obviously a super safe option for these people because you're not touching their cornea. So if they're regular enough that you can refract them and at least reduce some of their astigmatism and myopia to get them functional vision, then I think that's a really great option now that we have, a toric ICL as well.
That's a great case. Thanks for sharing that. Yeah, yes, I'm not sure if Blake, if you've done ICLs as well, but I have one patient I also treated. Again, you gotta find patients that have good best corrected visual acuity, at least in my opinion, and they can be really happy because of the price of the ICL. You want to have patients that have expected good outcome, and like you noted, they see even better than you would expect once they have the actual procedure.
Yeah, I think that's a great point, and I think we're going to get more into ICL in our next episode as well, which is cool. Couldn't agree more, Neda, on the optometric community doing doing more to gauge this. I have to give a shout out to Glaukos because they're actually partnering with a lot of ODs to give them, very, very relatively inexpensive topographies. It's crazy how many optometrists, do not have a topography, and they'll refract people and they can't quite get them to 20/20. Maybe they're 20/25-ish, 20/30-ish, and they just give them glasses, and it's just they don't have a topo to even look at that. And I think of how many people we can get to earlier if they just had that. So shout out to Glaukos for that program and getting topographies more in the hands of ODs. As we're wrapping up, just the last thing I wanted to kind of mention, Neda, we've talked about Epi-on and sort of that coming down the pike. I've had some issues with, infections after Epi-off. That's a known complication of cross-linking. Bill, I thought that maybe you could kind of talk about either what's the safest way to reduce risk of infection with Epi-off, and maybe a word about Epi-on and when that may come.
Of course. Well, first of all, Epi-off is what we have FDA approved here in the United States. It is a very safe and effective treatment. And it's really important that patients are identified and they get Epi-off cross-linking if they're candidates. And it's just been a great technology, which you guys all agree. The key is prevention of complications, and one is infection. And so one thing to consider is that the source, just like in cataract surgery, the source of infection is usually from the patient's own flora. So you can do things like use hypochlorous acid spray on the eyelids and lashes preoperatively to reduce the amount of bacteria that are present. And that should reduce the amount of bacteria that may put the patient at risk. I know many doctors, when we do Epi-off, we want to use a bandage contact lens. It does make the patient feel more comfortable, so you can weigh the pluses and minuses of that. I know some doctors will go even without it, but it's really painful for the patient. With it, it reduces pain, but there's a little more increase of infection, from my understanding. I'm not sure if any studies have been done. So the other thing I do that's probably a little different is I think there's too many holes in our antibiotics that are commercially available. So I like to use 2 antibiotics when I'm doing any type of Epi-off procedure. So I use both Polytrim, for example, and Moxie, like 2 separate types of antibiotics to get a little more coverage for the patient. Again, no studies. I just want to make sure I'm not missing anything. I do this for my PRK patients as well. So those are kind of my what I've been doing to try to reduce the risk of infection for my patients overall.
And what about Epi-on, Bill? When's that coming?
Well, Glaukos has done a great job. I think they've they advanced through the FDA pipeline a clinical trial that's already completed enrollment, and I know they're analyzing the data. They've done the first data analysis. As with anything that's going through FDA approval, they have to, it takes a little while, but hopefully that'll become available to us. Epi-on, if you think about it, there's no other treatment that I can think of, eye drop treatment, where you have to take off the epithelium than cross-linking. So it makes sense that if we just if they updated the formulation, which is what the Glaukos version has done, and allows the riboflavin to penetrate through intact epithelium, which is certainly possible, and then we can get very nice results with cross-linking and avoid the risks that are present with Epi-off. Again, the risks are low but real. So we can just lower the risk profile. And let's say it turns out that it's only 80% is effective with one treatment. You could always do more than one treatment. There's nothing that says that only one treatment should be done. And if it turns out that you can do 2 Epi-ons in a small subset of patients versus and eliminate the risk of infection, that may be worth it for many patients and many physicians. I'm hoping that the efficacy rate will be close to Epi-off, so that there won't be much of a difference, but we'll have to see with more data.
Those are really, really great pearls, Bill. You've been doing cross-linking way longer than we have. So I'm curious. I mean, I've read the FDA studies, and I know in the literature what the success rate of Epi-off is. But I'm just curious, since you've been following these patients much longer than we have after cross-linking, how often in your hands are you needing to do a second cross-linking for an Epi-off or an Epi-on patient?
Absolutely. Well, I did, from my FDA clinical trial from 2008, I did see a patient come back recently that I had to, I did do repeat cross-linking this year in one of the patients that was enrolled. So it can occur even later. That's why they need to keep following our patients. And with Epi-on, as part of a clinical trial through CXLO, and in that study, it's about a 1% risk of needing second treatments so far. That number could grow over many years. We'll have to keep watching our patients, but so far it's been about the 1% range. I think with Epi-off, from looking at the international literature, it's also in the 1 to 2% range. Some studies say 3%, but I think 1 to 2% at least. So that means we just have to follow patients over time, because they can come back 5 years later and have a little bit of a change. And repeat treatment is super simple to perform, and it's quite effective. I found that when you do that second treatment, not only do you stabilize them, often there's even more improvement in corneal shape. So even, let's say a patient was just drifting over time and they're just a little bit worse. You go, okay, let's do a second treatment. When you do that second treatment or like a booster, all of a sudden they get really nice improvement in the corneal shape as you follow them further along. So second treatments are excellent, and they should be offered if you do identify a patient has progressed a little bit. And obviously, just to point out two more things that make sure they actually have progressed. Like if someone's a little bit worse when they come back a year later, maybe it's because their eyes are a little dry. Maybe they wore their contact lens that day. So I like to get I have them come back another month or two later, optimize the ocular surface, and make sure it wasn't just an aberrant reading, that they truly are progressing. And it can take a little while to figure that out.
Wonderful pearls, Bill. This has been a great discussion. I think we learned a lot about AvaGen and where to place it in our practice, and how do we meet the refractive goals of our patients after they are treated with cross-linking, and as well as what's coming down the pike with future technologies. So just want to thank my co-host Neda, and also you, Bill, for coming on the show, and we really appreciate it.
Thank you so much for having me.
Until next time, this has been another episode of Ophthalmology Off the Grid. Thank you to Dr. Bill Trattler for joining us on this episode of Ophthalmology Off the Grid, and thank you to our listeners for tuning in. This has been Ophthalmology Off the Grid. Until next time.